Hey, thanks everybody for responding to the case of the month. Just a reminder, I'm going to try and do one once a month about the middle of the month. So kind of be watching for an email from me. I'll try and pick a case from that month and do it as an unknown. And so many people responded and it was fun. So I want to thank everybody who opened it and responded. And for those that didn't, don't be afraid to. As I said, you can't be wrong. It doesn't matter. Just think it through, think of what it is, and then we'll kind of work it out together. So this week was a limbal lesion. And when you think about it, the limbus is an incredibly immunoactive area. So much is going on there. The confluence between the conjunctiva and the sclera and the cornea. You have the limbal vasculature, which is very immunoactive. You have immune cells within the stroma of the peripheral conjunctiva and cornea. And of course you have the limbal stem cells, which provide a healthy corneal surface. So a lot happens there. Inflammatory conditions, rheumatoid conditions, and you all were obviously on the right track. So the differential diagnosis, many people selected SLK, superior limbic keratoconjunctivitis. That presents slightly differently. That's generally around the 12 o'clock position. The superior conjunctiva is very injected, often with filaments, and stains brightly with rose bengal, but not fluorescein. Nobody knows exactly what causes it, but it's more common in people with thyroid conditions. The only real treatment, people have tried silver nitrate and other treatments, the only real treatment is a conjunctival resection in that area, which works really well. Other people said it might be lid-related immune keratopathy, and that is right on. It's very close to that. As you can see in some of the photographs above, it's different than a staph marginal infiltrate. The staph marginal infiltrates tend to be circumlimbal, infiltrative with or without an epithelial defect, but they tend to be less focal and more sort of cigar-shaped. Other people said it might be a rheumatoid melt and or a collagen vascular related peripheral corneal melting or peripheral corneal keratitis. Those are less infiltrative and more thinning and melting, oftentimes with very few visible white cells. And again, I have a picture of that above. This was actually a flectinule, which is in the same category as peripheral immune keratopathy related to staph marginal disease. In fact, in the United States, about 95 to 98% of flectinules that we see are lid-related, particularly in children, as you notice in the child above, the 11-year-old girl picture above. So it tends to be a deeply infiltrative condition at the limbus. Now, this starts at the limbus, but as you can see with the little girl, it can wander into the central cornea, dragging a leash of blood vessels with it. In this particular case, very unusual in this country, but it can be associated with tuberculosis. And the tip-off here was the fact that it got better with steroids, then he stopped, and it got worse, and it got better, and it got worse. Tipped me off to the fact that it was probably an underlying systemic condition, and I sent him off for a TB test. And we found out that he had TB, we're treating his TB, now his limbus is better. So anyway, again, thank you so much for all your responses, and we look forward to a case next month. Thank you.